my last talk. You will have peace afterwards. Okay. So knee instability, and here what we'll talk is in congenital limb deficiency, congenital short femur, PFFD, and even fibular hemimyelia. We'll talk about the causes. It will be divided into three. The first thing is how to prevent knee subluxation during lengthening procedure, how to diagnose early knee subluxation during the lengthening, and how to treat knee subluxation once it happens, and then give some key concepts. So the first thing, the causes of knee instability, it's both ligamentous, bony, malalignment, it's a combination of everything. We know that most cases of congenital short femur, PFFD, they have ACL, PCL deficiency, whether they are completely absent or deficient, but the anterior, posterior, sometimes drawer sign, in many cases there is a soft end. There are also bony deformities that you should be fully aware. The normal development of the intra-articular component of the proximal tibia and distal femur is abnormal. There is no notch in the, or a flat notch in the distal femur. Tibial spine, sometimes it's non-existent. So it's not only the ligaments that are absent. It's not like a traumatic rupture of an ACL. It's much, much more complex, and it includes both the ligaments and the bones. Sometimes we have a malalignment that is added to this whole thing, and there is a maltracking of the patella. So it's a combination of numerous factors, and that's what makes knee reconstruction in congenital ACL deficiency extremely, I wouldn't say difficult, but it's unpredictable and mostly unsuccessful. Now, in persons who have a congenital short femur and congenital deficiency of the ACL, under normal activities, they don't have any problem most of the time. It's only when subjected to the stress of a limb lengthening that this laxity becomes apparent. The other thing is, irrespective of what technique of lengthening you use, whether it's an external fixator, circular, monolateral, precise nail, the dangers of knee subluxation remain the same. The next thing now, how to prevent knee subluxation during the lengthening procedure, and I think that's the best thing that we should concentrate. We should not concentrate on lengthening and then simply say like, okay, if a knee subluxation happens, I will deal with it. I think that's a wrong attitude. The correct attitude is simply saying, how can I prevent such thing from happening? So we know this, the type of knee subluxation, usually it's a posterior, very rarely anterior. So what are the steps that we can do? Most important thing is to maintain the knee in full extension. And that has to be clearly explained to the patient, to the nurses, to physiotherapists. Maintain the knee in full extension, whatever it takes. The knee will not sublux in full extension. So all these are things that can be done, starting with physiotherapy, and physiotherapy here, it's intensive, really intensive physiotherapy, like twice a day during the distraction phase at least. Bracing, Botox injection, it's controversial, but you lose nothing in doing Botox injection in the quadriceps. Pain control, pin tract infection, and then we'll go to these things. We'll go quickly one to one. So the best one really who can describe this, it's here I took it from special surgery from Rosbrook, Dror Peli also. It really emphasizes the importance of an intense physio. And again, the key success to any lengthening procedure is how you respect the intensive physiotherapy program. Electrical stimulation, hydrotherapy, pin tract infection, it's sometimes we neglect this. If you want really an intensive physiotherapy, you cannot have it if you have a pin tract infection. It's painful, the patient will not do his exercise, so they should be really promptly treated. Child who is crying, try to do physiotherapy with him and then see what you can get. Very, very important, small things like this that really will help in the rehabilitation program. Soft tissue releases, very, very important. And if you do ephemeral lengthening and you don't do a TFL release, if anything happens, it's malpractice. And I mean, that's serious thing. Always release the TFL during your index surgery, during when you apply, whether it's your precise or external fixator. You have to do it. Hamstring, especially the medial hamstring, also lengthen them. Now, spanning the knee. It's done routinely in my hospital. I do it now routinely, and it's done in almost many places, at least in North America. And you can span the knee with a circular fixator, with a unilateral, and with precise nail. If you put a unilateral fixator, the standard one, it's a Sheffield ring that goes across the knee. You have here a hinge, and that allows knee flexion and extension. During the night, you lock so that the knee is maintained in extension. During the distraction, also it maintained in full extension. Most important thing is to find the center of rotation of the knee where you put your phantom pin. And what really helped recently is that in the advanced LRS system, we have this, what is called the sandwich clamp, where you put your phantom pin here, and this does not interfere with the 3 pins that you put anteriorly into the femur. And with this, you attach your Sheffield ring, and you allow flexion extension, and you can lock it anytime. Extremely useful, and it's very easy to put in. There is absolutely no reason why not to use it. And last night, Scott Nelson showed me also, even if you don't have the advanced LRS, if you have an old system, the rail system of the Orthofix, how to put the Sheffield ring through an adjustment that he made, he developed. It's too bad that he's not here, but you can ask him. You don't need the advanced LRS to span the knee. You can also span the knee with an Elizarov frame, a simple 2-ring frame, and that's the hinges. Show you one example. That's a case of a congenital short femur. We stabilize the femur here, and then we want to apply a lengthening. So you put your precise nail, and you cross the knee with a circular fixator. So precise nail, it's not a contraindication to spanning the knee. You should span the knee if you feel beforewards that there is a deficiency in your ACL. And I said you can use a TSF frame, you can use a Elizarov frame, whatever you want. Another example here that you have to span the knee. So we have to lengthen with a precise, we have to lengthen and correct the deformity with the TSF, and you span the knee with your Elizarov ring. So there is always a way to span the knee, whether you use any type of lengthening device or precise. There is no excuse why not span the knee during a femoral lengthening of a congenital deficiency. That's how it looks like. It looks weird because the one who looks at that picture, if Dr. Mark will look at this, I said, like, what the hell are you doing? It's an Elizarov TSF. Here it's a midway between Elizarov and TSF, but you span the knee. That's the most important message. So in one word here, all these things can be done and should be done to prevent knee subluxation. The last thing now is reconstruction of a deficient knee. All of you know the super knee procedure. I don't have personally any experience with this. There are several questions regarding the super knee. Number one, as to the best of my knowledge, I couldn't find any reports in the literature describing the results of the super knee procedure before a limb lengthening. What is the success rate of a super knee in preventing knee subluxation? It's not reported. Maybe some people do it and know the answer, but couldn't find any reports. And what are the results of the super knee in reducing the subluxation during and after the lengthening? Again, I couldn't find any reported cases on this. Ligamentous reconstruction of congenital ACL deficiency has been reported. In fact, the biggest series was just published in 2019, a few weeks ago, by Kocher in Boston Children's Hospital. He has a large series. But this was not followed by lengthening. So we don't know what's the success rate of all this reconstruction after lengthening procedure. The same thing, there are several short series or case report that described successful outcome after congenital ACL reconstruction. But again, all these were not subjected to the stress of ligamentous of lengthening. How to diagnose early subluxation? It's very easy. Loss of knee extension. Once you have a loss of knee extension, this means knee subluxation. Stop the lengthening, shorten it, do all these procedures that we have just mentioned. And again, the key thing is maintain full extension. So whenever you have clinically loss of full knee extension and radiologically you see any signs of this, then it's a red flag and you should do something. I will just have 2 minutes. I have 2 minutes, correct? Yes. We'll go through 2 examples. If it happens and you detect a knee subluxation, stop the lengthening. Sometimes you shorten, you reverse your lengthening. Now you can do it with the new generation of a precise nail. You go back. You can easily do it with a circular or an external fixator. So the first case, if we have time, we'll go through this. But knee subluxation during the lengthening process. Stop the lengthening, reverse the lengthening, all the above techniques that have been mentioned. That's a terrible case of knee subluxation. In that case, there were no soft tissue releases that were done before. There was no spanning of the knee. I mean, that should be really history nowadays. Okay? Now, there are special type of brace that you can design with putting the hinge anteriorly and distally, mimicking an external fixator. And you can try this gradually applying it. And we had some cases that were successful in reducing the knee subluxation. Second case, that's an interesting one because this patient had everything. He had release of soft tissue. He had spanning of the knee with an Elizarov frame. And he had a precise nail for the lengthening, that spanning the knee. And it was a beautiful result. We obtained the lengthening. If you look here, the knee was perfect. That you can, in retrospect, think, but still, the full extension. The spanning was removed, and that's what happened. After removal, after completing the distraction, after completing the whole process, you removed, and then you get your knee subluxation. We have permission to show his picture, this patient, by the way. So we applied that was one of my colleagues, it was Mitch Bernstein, whoever know him. He applied this type of traction, pulling on the knee. We gave him Botox injection in the quadriceps, intensive physiotherapy, and it was successful in reducing the subluxation. That's a very good result. The third thing that you can apply, you can modify your external fixator, your Elizarov fixator. It's not an easy fixator to do. You have to play with the hinges to put them anteriorly. You pull anteriorly, and the gradual correction with the hinge here, the distraction rod here, you can reduce it. I'm sure you can do the same thing with the TSF also. And the last thing, as I mentioned, it's a reconstruction, knee reconstruction during or after really the subluxation. I could find only one report that gave successful results with reconstruction using the TFL. However, as I mentioned, the results, most of them are unsuccessful and failed to reduce the knee subluxation. So that's the take-home message. Very, very important to have in your head the knee instability, maintain full extension, early detection is most important, and stop the lengthening if there is any sign of subluxation. Thank you.